Hello, my name is Tonia Poteat, and I am on faculty in the Department of Social Medicine at the University of North Carolina. I am going to spend the next 45 or 50 minutes sharing with you a little bit of information about community engaged research as it relates to LGBTQ populations, with a focus on a few examples of my work with a lesbian community-based organization. I'm the director of the RISE Lab, Research in Sexual and Gender Minority Equity. And this depicts just some of the community partners that we work with, some of the projects that we work on, and at the bottom, the team that is part of the RISE Lab, including some staff and as well as some students, as a reminder that it takes a village to do this kind of work. I'll start just by outlining what I mean by LGBTQ health equity research, do a quick refresher of intersectionality, since that undergirds the majority of my work, spend a little more time focusing on what I mean by community engaged research, and finish with a few examples of community engaged projects. So health disparities, as you know, are preventable differences experienced by marginalized populations. Health equity, on the other hand, is elimination of these disparities that are achieved by eliminating the systemic, avoidable, and unjust barriers to health that exist for marginalized populations. In 2020, the National Academies of Science, Engineering, and Medicine published a report entitled Understanding the Well-Being of LGBTQI+ Populations. This report highlights the needs for attention to social and structural inequities that drive disparities affecting sexual and gender diverse populations, and it argues for new research, especially among LGBTQI+ people who exist at the intersections of multiple marginalized identities. So LGBTQ health equity research uses, that I conduct at least, uses an intersectionality lens and a community engaged approach. I believe that intersectionality is essential for advancing health equity research, and that community engagement is key for research that is rooted in intersectionality. Next, I'll share some quotes from the community about experiences with research that highlight where we have missed the mark in the past in relation to community engagement. One participant in this particular study by Reisner et al. Said that researchers ask the same questions, but there's so many other issues to be addressed, highlighting how researchers often ask questions related to their topics of interest or to the priorities of the funders, but that these may differ from the priorities of the community. Another participant said they come and get your data, but when it's over, they don't come back and tell you the results. Again, highlighting that we are missing that key component of community engaged research, which is dissemination back to the community to share their data with us. Another participant said research needs to take place in a neighborhood where I feel safe and welcome. Often as researchers, we conduct our research studies in places where we feel safe and comfortable, but not necessarily where the community members feel safe and comfortable. And another participant said, until you have housing and a job, why would you want to be in a research study? Highlighting the essential priorities of livelihood and well-being for communities that are not taken into consideration often when we're conducting our research studies. So next, I will move on to a quick review of intersectionality. I know that you've had a lecture in the past by the esteemed Lisa Bowleg, who really leads this work in the land of public health. So I will do just a quick review of the key tenets of intersectionality. Human beings are shaped by the interaction of multiple social categories, so things that we call race, ethnicity, gender, sexual orientation, age, and ability. And these categories, also called identities or social locations, are mutually constituted. Everyone has them, although some are unmarked. An example of this, excuse me, is depicted below in terms of what we mean by mutually constituted. So on the left-hand side in the picture, you see all the ingredients it takes to make a cake. However, once you bake that cake, you can't separate out the eggs from the sugar, from the milk, from the flour. We all exist as all components of these social categories. And what I mean by some are unmarked is that you will often see when people are talking about populations that they consider quote unquote the norm, that they will be unmarked in relation to race. So if they're talking about white people, they won't mention that they're white, but if they're talking about Black people, they'll mention that they're Black. Similarly, if they're talking about heterosexual people, they won't mention that they're heterosexual, but if someone's lesbian or gay, they might mention that in conversation. Again, reifying in almost a subconscious way that these are the normed categories. These categories exist within dynamic structures of power. And by structures of power, I mean laws, policies, economic systems, religious institutions, institutional policies and practices, and healthcare settings, for example. And you'll see below a few of these examples. When we're talking about laws, you can see Plessy versus Ferguson was one law that had a huge impact on what it meant to be Black in America, depending on what part of America you lived in, as well as Brown versus the Board of Education, the gutting of the Voting Rights Act that took place a few years ago in the Supreme Court. The recent Dobbs decision has a huge impact on bodily autonomy in the United States. So wherever we sit in terms of our social categories, they're definitely influenced by these structures of power. In the middle, you'll see capitalism and wage labor, wealth and income gaps. And on the right-hand side, religious exemptions for things like provision of contraception or birth control, and other social norms. All of those things influence what it means to be living at our particular intersection. These structures of power create interdependent forms of privilege and oppression that vary based on our intersecting social categories. You'll see on the right a graph that was adapted from Sylvia Duckworth's Wheel of Power Privilege to incorporate intersectionality. You can see in the center there is power, and the folks that are closest to that power are the unmarked categories that we mentioned earlier. And as the farther you move away from these centers of power, or the more marginalized you become, the more one is subject to oppression based on distance from the center or control of power. And then on the outside of the wheel, you'll see that ways that power manifests in the lives of folks who are marginalized through things like ageism, sexism, transphobia, racism, etc. Another way to think about this is in research is thinking about how we conduct research on these social processes. And sometimes what we see in intersectionality research, or research that uses the term intersectionality, is that people will highlight the individual categories like gender, race, sexual orientation, and then they will highlight the social and structural consequences of those individual categories like poverty, mass incarceration, unemployment, health inequities. And they won't make explicit the really key component that makes an analysis intersectional, which is that social process in between. The link between gender and poverty is sexism. The link between race and mass incarceration is racism, for example. So it's really important when conducting intersectionality-based research and community engaged research, especially when working with marginalized communities, is to make it clear that you as the researcher or the implementer understand the social processes that link these categories to their social structural consequences, and that when you do your analysis and present your findings, that this link is clear. So in summary, intersectionality is a framework that increases engagement, that can increase engagement of marginalized communities in research if these core tenets are applied throughout the research endeavor, from the idea to the analysis. So when we are engaging with communities, it's important that we recognize mutually constituted social categories, that we identify the dynamic context specific power structures and relationships, including our own, reflect on how we as researchers in this context of power influence the research question and the implementation of research studies, and that we center the marginalized communities from the very beginning. There is growing attention to strength-based intersectionality that focuses on thriving, flourishing, resistance, and resilience. That can be an important way to think about approaching work with marginalized communities that is solution-focused. So after that quick review, I'm going to move on next to what is community-engaged research. Community-engaged research, or sometimes abbreviated CER, is really about the process of creating, building, and supporting partnerships. The Centers for Disease Control and Prevention defines community-engaged research as the process of working collaboratively with groups of people affiliated by geographic proximity, special interest, or similar situations to address issues that affect the well-being of those people. I think our representative, Ayanna Pressley, said it more succinctly when she said the people closest to the pain should be closest to the power, driving and informing the policymaking. So that is what community engagement is really about. I'll compare now community engaged approaches to research to our traditional forms of research. On the left-hand side of the table, you'll see different categories related to conducting research: selecting the topic, designing the study, seeking funding, engaging participants, collecting data, and analyzing, interpreting, and disseminating the findings. In the traditional approach outlined in red, the selection of the research topic has typically been based on epidemiologic data and funding priorities. The studies have been designed based on those that are most scientifically rigorous, and that is the sole criteria. The funding that is sought is to pay primarily for research-related expenses, and the participant recruitment is based on what the literature tells us is the most effective form of recruitment. Data collection and implementation of the study uses psychometrically validated tools, and the data is typically collected by academics. And then data analysis is done by the academics. The academic institution or researcher owns the data, they analyze the data, and they publish their findings in academic journals. And that has long been the traditional approach to research. However, using the principles of community-engaged research, we want research goals that are consistent with the community's priorities. We want strong partnerships that have equitable power sharing and responsibility. And notice I don't say equal, I say equitable. Community organizations have a mission that is not research. So thinking about what form of power sharing and responsibility sharing is equitable is going to be important. It's going to be important to consider the organization's priority and what they're here to do. Capacity building and research sharing goes in both directions, building the researcher's capacity to work with community and the community's capacity to work with research, and effective dissemination in ways that will be most useful for community. So community engaged research happens along a continuum. There can be research that's community informed, meaning there's maybe a community advisory board that reviews documents, reviews data collection instruments, but really doesn't make decisions related to the research study. Community involved research involves the community as a collaborator who really is engaged from the beginning of the research idea through the conduct of the study and dissemination, all the way to community directed, where the community really leads the research study and the academic is the person who sort of follows the community's lead. So I'll share with you now a study that is based on community-based participatory research principles. And in these principles, the selection of the research topic is done by the community. They're intimately involved in the design. Funding is available for the community as co-investigators. The recruitment of participants is guided by the community, and data collection instruments are developed in partnership with the community. The data is collected by the community, wherever that is feasible. And if it is feasible and desired by the community, that capacity is built in order to do that in the most effective ways. And the data is co-owned, co-interpreted, and the community identifies the most appropriate form of dissemination. So now I'll move on to the examples. The first example will be of a community-based participatory research project that had high levels of community engagement. And I will move on to some other work that our lab has been doing with Zami Nobla. So Zami Nobla is a national organization of Black lesbians on aging. We at the RISE lab, both before I was at UNC and since I've been at UNC have been partnering with them for many years, working on issues of importance to lesbian health. Our first study was really a needs assessment, and it was built on this background data from the Caring and Aging with Pride study that was conducted and published in the 2010s, maybe a decade ago. Caring and Aging with Pride study involved the Caring and Aging with Pride study enrolled over 2,000 LGBT older adults and asked them a series of questions. You can see on the left-hand side of the screen that a third of the participants identified as lesbian, 61% as gay men, 5% as bisexual, fairly evenly divided between bisexual men and women, and then 1% queer or other identities. 23% reported having poor general health, 44% reported physical activities that were limited by health problems, 31% reported current depressive symptoms, 48% among those who identified as transgender, 39% reported suicidal ideation at some point in their lives, and this number was 71% for those who identified as transgender. And when asked about whether they were afraid of accessing health services, 15% reported being afraid of getting healthcare outside the LGBT community, and 8% were afraid of getting healthcare within the LGBT community. When they were asked about their most needed services, priorities included senior housing, transportation, legal services, access to social events, and support groups. So our question in partnership with Zami Nobla is, does this data really represent the experiences of Black lesbian elders, given that 33% of the respondents were lesbian and few of the participants were Black? We wanted to know, do these needed services actually reflect the needed services in the Black lesbian elder communities? To answer that question, we conducted focus groups with Black lesbians in the metropolitan Atlanta area where Zami Nobla is located. Participants were eligible if they were identified as Black, lesbian, gay, or self-gender loving women, 40 years or older, and we compensated them with $50 for participating in the focus groups, and the focus groups were conducted by the executive director of Zami Nobla. We conducted 14 in-person focus groups There were approximately 100 participants through all of the focus groups. Each group lasted about 90 minutes. The groups were recorded and transcribed verbatim by a professional transcription company. We conducted open coding with an iterative codebook for analysis and used the thematic content analysis to answer our research questions around priorities. And our goal was to develop community-derived recommendations for services needed by Black lesbian elders. Recommendations that were identified from this research included the desire for community connections, the desire for holistic and complementary care, economic interventions, both education as well as access to resources, accessible, age-appropriate information about services that might be available to them as elders, access to intergenerational activities to engage with people who were younger than them and share their knowledge and learning, as well as to learn from them. LGBT competent healthcare providers with shared identities. Participants described wanting healthcare providers who shared at least one of their identities, either Black or women or lesbian, gay, or bisexual. And then LGBT-focused senior housing was a big priority. So using this data, Zami Nobla then decided to prioritize the identification of and creation of accessible housing for Black lesbian elders in Atlanta. And they did so. They identified their first residential housing for Black lesbian elders. They identified the house. They raised money through donations to renovate the house. And you can see they've called it the Biggers House, which is named after Edith Biggers, one of the board members of Zami Nobla, who donated the home. And then through the donations given to Zami Nobla, they renovated the home. And you can see here, they've now created a residential house for Black lesbian elders, and they moved in their first resident last year. So this is one example of the way that community-led research can really lead to a difference in the community. When the organization itself can take the research findings and use them to make change. This is an example of community-led research where Zami Nobla defined the research question, they drove the project and set the timelines, they determined the approaches and the staffing. In fact, the director of Zami Nobla is the one who conducted the research data collection. Zami Nobla led the analysis, interpreted the meanings, they determined the dissemination plan and how the findings were used. There are other forms of community-engaged research that are not community-led necessarily, but are community-engaged. Community provides input on relevant issues. They're consulted regarding the acceptability of study designs. There is funding available to them as consultants or participants in the research team. They are consulted regarding the strategies for participant recruitment. The instruments are tested and adapted with some involvement in data collection where appropriate, and the results are shared with the community for interpretation and dissemination. And we have engaged with Zami Nobla in research that was community engaged, but not necessarily community led. One of those studies was a study of sexual minority women and breast cancer. So we know that Black women are diagnosed at later stages of breast cancer due to a younger age when they develop breast cancer, often before the age of screening, and longer times between mammograms. Sexual minority women have a higher risk of breast cancer than heterosexual women, and some studies suggest lower rates of screening. However, the lack of data on breast cancer experiences of Black sexual minority women is really striking. We conducted a systematic review of the literature and found almost no data on Black sexual minority women. For studies that focused on sexual minority women, a small proportion were Black. And for studies that focused on Black women, they often didn't ask questions about sexual orientation. So the Access Project aimed to fill this gap with data on engagement and care after diagnosis or an abnormal screening test among Black sexual minority women in particular. We chose to partner with Sammy Nobla on this project because of their strong and consistent and long-term relationship with Black sexual minority women communities, and also because of their demonstrated commitment to breast health. They had previously had a breast cancer forum. They had provided mammograms in the community for women, and their director is an active breast cancer survivor who continues to be engaged in the breast cancer community. So Marianne Adams is the executive director of Zami Nobla, who, as I mentioned, is a community activist, a researcher, and breast cancer survivor. And Zami Nobla was engaged through all stages of the study. So we reached out to them as we had this idea about the study. We asked them if they wanted to partner with us, and they did participate in each level of design, data collection, and interpretation. And where we had additional collaborators, because this was a study that we really wanted to reach far and wide. These collaborations included with the PRIDE study, which is a longitudinal study of LGBTQ people in the United States. They have thousands of participants in the PRIDE study who complete an annual survey and who volunteer to be approached for participation in additional studies. The Love Research Army is run by Dr. Susan Love, who is a breast cancer researcher, and the Research Army is the group of people who have signed up to receive information about potential breast cancer research studies that they may be eligible for. Erica Hart is a breast cancer survivor and a social media influencer who we approached and who agreed to work with us on disseminating the study. And then other organizations included Living Beyond Breast Cancer, the NIH, and the National LGBTQ Cancer Network. We worked with Amy Nobla and some of their members to develop the recruitment materials, which included the flyers that you see here, as well as social media sites, Facebook, Twitter, and as well through word of mouth in the community. Our social media engagement was really important. We had hundreds of followers. There were new subscriptions weekly. We included, in order to be as transparent as possible and as community engaged as possible, we included the study investigator bios. So myself and Dr. Lori Dean from Johns Hopkins were the study's investigators. And we included our pictures, our bios, and we uploaded 2 different videos as the study progressed. One describing our motivation for conducting the study and why it was important to us, and another follow-up video later about why we continued to enroll and felt that the study was important for the community. This level of transparency and accessibility of the study investigators was really designed to engender trust in the community, and it was highly encouraged by Zami Nobla that we do this so that people could see us as real people. When data collection was complete, we took a look at the recruitment results to see where we had most effectively reached different people that we wanted to engage. The study overall engaged sexual minority women throughout the United States. We did a qualitative piece that focused all on Black sexual minority women, but the survey itself focused on all sexual minority and heterosexual women, Black women, white women, and women of other races. So we wanted to look back and see which organization helped us engage which groups more effectively. You can see that the Army of Women recruited 32% of sexual minority women, so they were the most useful source of recruitment for sexual minority women. And Army of Women was the former name of what's now called the Love Research Army. Facebook recruited the most Black women, with 21% of the Black women participants being derived from Facebook. And Zami Nobla was by far the most effective at reaching Black sexual minority women, with 40% of them reached directly through Zami Nobla. I think it's important to talk about some of the challenges that we faced along the way of collecting data that was designed to include a large enough number of Black sexual minority women to have a reasonable analysis and highlight the needs of this population, but included other groups. This is a busy slide, but what you can see here is that we started data collection in 2018 through Zami Nobla. And then as we reached out to other organizations, the Love Research Army was really prolific in helping us to recruit participants. So you can see that the blue line, there was a huge peak and a continual rise in the number of participants within the first 6 months of data collection. And then you can see in the red, if we look specifically at data collection for the survey among Black sexual minority women, that line is sort of much less steep and sort of creeps up until it reached our target of 100. So our goal was to enroll no less than 100 Black sexual minority women in this study in order to have a large enough sample size for specific analysis. What you see in the little boxes here are the different activities that took place for recruitment. And while the online recruitment was incredibly effective at reaching groups that were not Black sexual minority women, it was really the face-to-face engagement with communities that Zami Nobla did that really helped us to reach the Black sexual minority women. And it took us well over a year to do that. And it was important to us. We did have a conversation around January of 2019 about whether we would continue to leave the survey open and try to recruit people, given that we had reached our overall sample size, but not our goal for Black sexual minority women. And we made the decision that it was really important to us, since that was the driver behind the study, to reach Black sexual minority women. And our minimum sample size for that. So we made a conscious decision to keep going with recruitment efforts in order to make sure that we had enough participants from this group. So here is some of the quantitative findings from that survey. Not shockingly, when we looked at the question of care delay, so we asked participants if they delayed seeking care, receiving care for 3 months or more after receiving a breast cancer diagnosis or an abnormal screening test result. 5% of heterosexual white women reported a care delay, 10% of white sexual minority women, 11% of Black heterosexual women, and 29% of Black sexual minority women reported experiencing this kind of care delay. That was not shocking to us, but as you can see, it is still disturbing. We also noticed that participants who were Black sexual minority women were much younger than the other participants, with the average age for the white heterosexual participants being 58 and 49 for Black sexual minority participants. We saw anticipated differences in education, income, unemployment, and health insurance, with college education levels actually being lowest among Black heterosexual women, followed by Black sexual minority women. Income levels being lowest among Black women, both heterosexual and sexual minority women. unemployment being highest among Black heterosexual women, and health insurance being lowest among Black women, heterosexual, and sexual minority. We also included in the survey information around scales that measured social support and stigma. For the social support score, higher scores indicated greater access to social support, and you can see the lowest social support scores are among Black sexual minority women. And then the stigma scale was about experienced stigma, and the higher the score, the greater the experience of stigma, and you can see the highest score is among Black sexual minority women. We also use the Charlson Index to track other comorbid conditions other than breast cancer that women might have been living with, that might have impacted their ability or access to care. And you can see it was similar for all participants, their Charlson Index score. When we conducted an adjusted logistic regression analysis, we controlling for or including income, stigma, and social support, you can see that the odds of delay was greatest for Black women, and particularly for Black sexual minority women. The original model included just a structural factor like income. And then for the second model, we added stigma. And for the third model, we added social support. And so even in the third model, when we were including social support, stigma, and income, the significance of the care delay for Black sexual minority women remained high, with a 5-fold odds of care delay compared to other women in the study. And this is even though income remained significantly associated with care delay. I'm sorry, income, mean stigma score, and social support were still relevant in this model. You can see that income was no longer statistically significant since the confidence interval crossed 1, but stigma and social support remained significant, but still 5-fold higher. We also wanted to understand reasons for delaying care among the participants who did so. And so we looked at factors at the structural level, which included things like cost, transport, and childcare. At the institutional level, which included things like inability to reach the healthcare provider to schedule a follow-up appointment. Interpersonal factors like distrust of the health system, fear of experiencing stigma in the health system or by the healthcare provider. Intrapersonal reasons like feeling that it's pointless, being embarrassed by the diagnosis, or not wanting to worry other people. And then what we labeled minimization, which means they had other priorities, they weren't experiencing any pain, they didn't believe the test results. And then you can see from the bottom that the blue bars represent white heterosexual women, the orange bars represent white sexual minority women, the gray bars Black heterosexual women, and the yellow bars Black sexual minority women. And for each of these reasons, except for distrust and fear of stigma, Black sexual minority women had the highest proportion reporting these reasons for delaying care: structural, institutional, interpersonal, and minimization. Importantly, after we collected these data, we owed our community partners the sort of dissemination that they requested. So Zami Nobla felt it was important for us to share the findings back directly with the community. So we held a Zoom-based webinar with the membership of Zami Nobla, sharing our findings. It was entitled "This is a Mess Right Here," based on the qualitative results that I didn't share with you here, but that's a quote from one of the participants in the qualitative portion of the study. And then on the right-hand side, we were also contractually obligated and happy to do so, to share our results with the Dr. Susan Love Foundation. And we held a webinar with them as well. So our conclusions were that sustained community engagement was really essential for reaching breast cancer survivors who are multiply marginalized, and that intervenable factors associated with care delays, including increasing social support, decreasing stigma, and reducing structural barriers to reduce delays in accessing care. So our next steps is to continue to partner with Zami Nobla as we seek funding for research with health systems to identify potential intervention points. So our goal is to now move from, now that we understand somewhat the experiences of cisgender women, particularly Black sexual minority women, in seeking to access breast cancer care, we want to move to the health system and understand what is actually happening in the health system and where interventions might be possible there. Stepping back from these particular studies and thinking and the findings related to breast cancer, I think it's also important to step back and look at us as a team at some of the lessons that we learned. And I'm going to share some of those with you. So the dynamics of power and privilege exist within groups that are labeled the same. So for example, Black lesbian elders. So I identify as a Black lesbian. Zami Nobla's leader, Marian Adams, identifies as a Black lesbian. But we are different from each other. And the women who participated in the study were different from each other. And one of the things that we found challenging is recruiting enough participants with diverse socioeconomic background. Conducting the survey online did pose some challenges for people who may not have been comfortable with an online format. And that's one of the reasons that reaching out in person and bringing a tablet or having people fill out the paper forms that we later entered was really important for reaching the population that we wanted to reach. We didn't want to just assume as long as they were Black and lesbian and elder that they represented related diversity within a community. In terms of community engagement, there were dynamic and complex insider-outsider components. Being from the community is not the same as being in the community. So even though I'm a Black lesbian elder, it was still important for me and Dr. Dean to create these videos to humanize ourselves and the experience of research, to encourage participation. It was also important that we didn't make assumptions based on our quote unquote insider status, that being familiar with the community as a member of it doesn't mean we're familiar with all aspects of community, and that we approach it, as the Buddhists might say, with the beginner's mind, and really be open to learning things about a community to which we may feel like we already belong. We also found that stigma and shame impacted research participation as well as access to social support. I think one of the most surprising findings for us in the qualitative phase of the study was how much shame participants described around their breast cancer diagnosis and not wanting friends and family to know. And some people didn't participate because they didn't want to potentially be identified as someone who had breast cancer. Trust was essential. So those videos, those webinars being available and humanized for the community was important, but it was also important for us to have adequate financial incentives. And we ended up, when we advertised for participation, we only had funding to pay $25. So that was important to us, that we have the survey be short enough to make it worth it. So I think the survey ended up being about 20-25 minutes long. So we said $1 a minute to get $25 for 25 minutes of people's time. And I think that was really critical, that we didn't ask people to do a whole lot of labor without reasonable compensation. I know many people struggle with their institutional review boards. around volunteerism and notions of coercion, but community members have presented very strongly that they deserve to be compensated for the labor of participating in our research studies, and that not doing so is actually not seen as ethical by them. This is the study team for the breast cancer project. You can see Marianne Adams and Sammy a little bit at the top. Lori Dean, who was the other PI on the study, at the bottom left. And then the other people that you see pictured here, Dr. Naomi Green, Dr. Joanna Malone, and Sophia Geffen, were all graduate students at the time and helped us implement the study. So in terms of a way forward for community engaged research, it is difficult and slow. As I showed you in that graph, really making sure that we reach the population we were trying to reach required multiple modes of outreach. So we couldn't just do an online study. We also had to show up in places with a tablet or with a written or a printed out survey, and allow people to access the study in ways that were most acceptable to them. And so doing community engaged research in that way is slow and challenging, but I think it's also the right thing to do. There are also times when there is anger, resentment, and distrust aimed at researchers. These are normal responses to oppression, and most of us, if we're at academic institutions, then we're affiliated with institutions that have been oppressive in their histories and maybe in their current nature. And people may respond to your affiliation without it being about you at all, and that it's okay. It's okay to show up over the long haul and to understand that anger, resentment, and distrust are normal, to continue to be present and to be authentic in the face of these really natural responses, and to show that the community and their priorities matter to you. And that is a way to build trust. Doing so is incredibly rewarding. I believe that when we do work through an intersectionality lens and a community engaged approach, that we generate better quality data, we build long-term productive relationships that generate data for real change. One of the ways that that is manifesting in our relationship with Zami Nobla is that we conducted that needs assessment many years ago. We finished the breast cancer study a couple of years ago, and are moving forward on looking for second opportunities to intervene there. And when the COVID-19 pandemic hit, Zami Nobla reached out to us to help understand the impact of the coronavirus pandemic on Black lesbians and understand their needs in the context of this sort of changed pandemic world. And so we've had the pleasure of continuing to collaborate with them on the COVID-19 study. So that's all I have for today. I want to thank you for listening. I want to apologize for not feeling at my best today. I didn't want to delay recording this for you all. So I appreciate your patience as I coughed and got water. Hopefully what was here was useful to you. And I am available. I think Dr. Beach will have my contact information, my email, if you want to reach out to me with any questions about the presentation. I hope you have a great rest of your day.